Why do you always tell me my speaker is not working? My speaker is working just fine. Good morning, Vietnam. Good morning, Vietnam. Anna, it's tomorrow. You go under the knife, so to speak. Okay. You're having it here or you're going home?
So technically it's through Walter, which is for him.
Uh-huh. You're having it here. Okay.
Yeah, it's at Grass Lake.
Oh, that's good center. They have good surgeons there.
Yeah.
Okay. You've got your ducks lined up. You have someone to drive you and all that. Okay. I ran into Coach Thompson. She said something about your mom actually coming up to. That's so sweet.
Yeah.
What a great mom.
Yeah.
What a great gal. Just kind of gets you right. That's really cool. She's doing that. Oh. You took the roommates.
Yeah, actually, I'm sure she probably will.
Oh boy, they're probably gonna say, hey, did you get hurt one often?
Right.
Well, Hannah, when you become a mother, you'll understand. You'll do it for your kids too. Becca, can you, oh, you're still connecting. Becca, can you hear me all right?
Yeah,
You feeling better or you still feel awful?
I feel better.
Okay. So maybe you're on the mend.
Yeah.
Fingers crossed. So I did a Zoom link for tonight as well. So I'll just expect you to Zoom as well since you're,
Thank you.
yeah. Rest, relax, get better, all that. Okay, Becca, I want you to tell me something. All right, do you see the slides move?
Not right now.
No?
No.
Here we go again. I don't either, and it is really annoying.
I wonder if it's because, like, I don't know, usually it'll say shared screen at the top, but right now it's not saying that.
Yeah, and I don't know how to make it say that because sometimes it says it and sometimes it doesn't. Okay, it says you are screen sharing. Now do they move?
It just says the management treatment surveillance slide still.
Okay, that means it's not moving. So. Come on. Let me do it this way. That's all we can do. Oh, this is annoying. It doesn't work. Afternoon, everyone. And we have another of our group who has fallen under the whatever it is that's going around and getting everyone sick. So there'll be a Zoom link for today and for tonight in case if anyone happens to leave this class and then promptly puke, you can Zoom tonight as well. So it seems like a rite of passage in this class. You have to get sick before the end of the semester. Let's all remember Hannah, she has her procedure tomorrow for her right leg? Left, for her left leg. So that hopefully she can get back on the diamond. And you're infield? Pitcher and outfield. Okay, so you're kind of all the above. All right. We were talking about cystic fibrosis, and we got to the part about genetic testing. And remember that the genetic tests include a panel for the 23 different main alleles of cystic fibrosis. That will get them, but it won't get all of them. The most important thing you need when it comes to the patient with cystic fibrosis is a comprehensive treatment plan. So you're trying to prevent things like remodeling of the respiratory system. So we talked about the bronchiectasis that develops over time. This, where you get kind of these tram track sort of lines that radiate from the hyla and the rings. They represent these cysts, and you see them typically, you really can see them there in the upper lobes. So to do that, you need to get a comprehensive plan. First off, you want to help clear out the mucus. You can do this with physiotherapy. You can also do this, it's called chest physiotherapy. Yes, there is such a thing. And then you can do this with some medications, and it's not uncommon for people with cystic fibrosis to have standing, oh, good night, it's really coming out now, to have standing prescriptions for many of these medications. Many of these are medications you've already heard before. So the beta-2 agonists, the inhaled anticholinergic agents. These would be things like Zopinex, levalbuterol, or albuterol, which is usually generic now. The trade names for that are Ventolin or Proventil, or it's usually generic nowadays. The generic works just as well as the label brands, and it's a lot cheaper. Also, you can use mucolytics. These are drugs that cleave mucus, and you can get it in health food stores. And acetylcysteine. It's usually just called NAC. You've heard of that before? You can get it in health food stores. This form for people who have cystic fibrosis is an inhaled form. So this inhaled form is going to help chop up the disulfide bonds in the mucus glycoproteins. And then they also use a nuclease. It's inhaled, it's called Dornase. Dornase. That's D-N-Ase, Dornase, oral Dornase. So it's Dornase alpha is the name of it. It's an inhaled DNase. You take that with the inhaled N-acetylcysteine, that tends to chop up the mucus so you can clear it much more easily. Airway inflammation can be diminished by using azithromycin. So this is a macrolide antibiotic, but when it comes to the airways, for reasons that aren't completely clear, it seems to have anti-inflammatory capabilities. So long-term use of azithromycin can diminish airway inflammation. And if your patient starts to show hypoxemia, and how are you going to detect that? Very easy way to detect that. Sorry? You don't even need to draw blood. Oxygen level of the blood. Yeah, Maddie, go ahead. Go ahead. No. You went like you put something on your, what's it called? Pulse oximeter. You just stick a pulse oximeter on their finger and that'll measure their blood oxygen. So it's even easier than drawing blood or looking for blue lips or something like that. If you have hypoxemia, you can give them supplemental oxygen. And it's not uncommon for families with a kid with cystic fibrosis to have oxygen tanks around the house. One of the big things about oxygen tanks, you cannot smoke around an oxygen tank. And if you are distributing an oxygen tank to a family, you must make that crystal clear. If your family members are smoke, you get your backside out of the house, you smoke outside the house. You don't smoke around an oxygen tank, or else you will get this thing called kaboom. That oxygen is extremely explosive. And in fact, they might even give you a sign to put on the front of the house. Oxygen tanks around, no smoking. And you need to tell the parents, you need to stand firm on this. Someone lights up in the house, you kick the butt out of the house. No smoking in the house. It's dangerous. Really, 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 really dangerous. Can you vape? Nope, can't do that either. Plus, that smoke is going to irritate the kid's lungs. So no smoking, no vaping around the kid. And if you have to insult, Aunt so-and-so, who's a, 20-pack a day smoker or something like that, and it's going to offend her. She should have quit long ago anyway. Oh, I'm so offended, I'll come to your house for Christmas. Oh, darn. Have fun. It's your kid. You got to make hard choices, and that's one. Oh, I don't like confronting people. Learn to confront people. This is your kid. Question?
I remember looking at the ATI, and it talked about expectorants like Mucinex. Exactly used too.
Guaifenesin. Yeah, guaifenesin loosens the attachment of mucus to mucous membranes, and it'll tend to make it a bit more runny, to put a little more water into it. That can also help mucus drain from the sinuses and what have you. You want to use that judiciously. It can help, but it can also make things flow too much. So yes, guaifenesin is available over the counter. There's a liquid form of guaifenesin as well for kids who can't swallow tablets. The liquid form too. The tablets, even the ones sold out of the counter, they're extended release. You can't crush them. The liquid form you can take you know, a little bit more, so on and so forth. With the tablets, you can't really do that because they're extended release. You can't crush them. So the liquid forms, which are even available over the counter, can help you do that. So yeah, guaifenesin is a definite possibility. It's also a relatively inexpensive drug. The prescription forms, they do a prescription form. They used to call them aqua tabs. I still make those. The 1,200 milligrams extended release, they work for 12, in fact, over 12 hours. Those you can't cut. You have to swallow them whole, and they're horse pills. They come as a 600 mg tablet, which is easier to swallow, but again, you can't squash it. Now, I think Bayer Corporation makes a version that's not extended release that you can crush. You know, let me look that up. I read that last year, and they might have changed that because that was kind of changing. The liquid forms definitely are still available. And some doctors' offices even will have samples of liquid guaifenesin they can give to families. So yeah, guaifenesin is one you can definitely use. That was a very long-winded answer to a very simple question. Sorry about that. Were you thinking more of like nasal sprays, Afrin, things like that?
No, I was looking through, 'cause when you brought up mucolytics, it reminded me of the ATI.
Yeah, ATI mentions guaifenesin because it's widely used. It's pretty safe. Some kids on guaifenesin, apparently it makes them hyperactive. That's not that common. But there are reports. I'm not so sure that's linked to the drug, but that's in the literature. That's one of the reported side effects in kids.
For the ATI though, it talked about, for the mucolytics, it said just acetylcysteine, I don't know how to say it. And
Acetylcysteine, yeah.
Yeah, so is that different than the N?
It's N-acetylcysteine means that the acetate group is attached to the nitrogen.
Okay, so it is different?
They're the same thing.
Okay.
Yeah. And this form, you can buy it as a tablet over the counter easily. And some people take it because it's an antioxidant. And there's a guy online who's actually a very good doctor who said he took it during the pandemic. Of course, he's working with sick patients every day. This guy's a respiratory doctor, so he's constantly dealing with very sick people. He took it because he thought it would help him stay away from the COVID cooties. Okay, I shouldn't be flippant like that. The disease killed a lot of people. Well, continue to kill people. But the inhaled form is usually what you'll get for people with, and that's usually prescription. Is there a liquid form sold over the counter? I don't think so. Let me check that too. I'll check the cake. So guaifenesin, check that. Liquid, is it sold over the counter? Okay, check that. The other thing you need is that the cystic fibrosis patients are subject to lots of respiratory infections. So the neonates and young children, their respiratory infections are often staphylococcal pneumonia, or sometimes in the hospital, if they're in the hospital, they can get a MRSA pneumonia. In teens and adults, they tend to get Pseudomonas aeruginosa pneumonias. Pseudomonas really likes the mucus and it colonizes the mucus. So these are more common in teens and neonates, small children. It tends to be staph and MRSA pneumonias. This one you have to treat with intravenous vancomycin. This one you can treat with anti-staphylococcal penicillins, so dicloxacillin, oxacillin, drugs like that. Pseudomonas aeruginosa, there's inhaled aztreonam, which works quite well. That is Caistin. Caistin is inhaled as, that's a monobactam that works quite well for these types of Pseudomonas infections. Exacerbations are caused essentially by coughing, coughing fits that won't go away because of the sputum, dyspnea with exertion, fatigue, decreased appetite, fevers. If you do some sort of pulmonary function test, there'll be a 10 to 15% drop in the FEV1. So it's very common to make sure that families have a spirometer. And the family needs to be trained how to use it. And they need to know what the baseline is, and they need to know how much of a drop is significant. If there's a 1%, 2% drop, big deal. You got up and you're not awake yet. If there's a 10 to 15% drop, that's significant. Auscultating the chest for parents who don't know what they're doing, there's so much mucus, it's going to be hard to hear anything. Now, you're the professional, you'll be able to know what to listen for. Parents, some people send parents home with stethoscopes. Not so sure that is much help. Doing quick spirometry is much easier and is much easier to interpret. For milder exacerbations, you can use oral regimens of antibiotics. You can use things like doxycycline or Bactrim, trimethoprim sulfamethoxazole, to treat staph infections. For gram-negative infections, you can use ciprofloxacin or levofloxacin. So in that case, the fluoroquinolones are very effective. For serious exacerbations, they need to go to the hospital and they need to have IV antibiotics. They need to be treated until they get back to their baseline breathing. That's usually a minimum of 10 days. They may need to be treated as long as 3 weeks. Over time, these repeated exacerbations will lead to irreversible respiratory failure and ultimately death. Now, if they get to that point, then they can have a lung transplant. That, of course, comes with its own set of risks and challenges, in addition to being on immunosuppressives for their lifetime. The other issue with guys is infertility. Now, typically in guys, the vas deferens is malformed, and in some guys, it's even missing in guys with cystic fibrosis. The testes, however, still make good sperm. That sperm can be removed through needle-based procedures, and they can still have children using assisted reproductive technologies. One thing you want to look for, and Maddie, you were on the right track, is distal clubbing. If you see clubbing of the ends of the fingers, you might remember that in your pathophys book. Oh, I see some people nodding. You remember that. You get the clubbing of the fingers. That's an indication essentially that you're starting to have decreased oxygen saturation. Nasal polyps are also pretty common. Fortunately, surgical removal of nasal polyps usually is not necessary anymore because nasal steroids can shrink those polyps, and surgery is usually unnecessary. So they may need to be on usually nasal steroids, which are usually very well tolerated. One issue with people with CF is Aspergillus fumigatus is a common fungus that's found in dust. Your bread molds that grow on bread that's too old might be Aspergillus fumigatus. If you have anything around the house that's growing any sort of mold, it's a very good chance it's Aspergillus. It's a very common mold. People with CF can have hypersensitivity reactions to it. And because people with CF tend to get cavities in the lung and in their sinuses, that are walled by mucus. The fungus can get trapped inside these, and the fungus can grow inside these. So the way to detect if they have this sort of, it's called allergic bronchopulmonary aspergillosis. Allergic, people keep putting this here, and I never use it. It's always in the way, and it's really annoying. Allergic bronchopulmonary Good night, that's a mouthful. The way to test for this, there are good tests to look for immunoglobulin E against the antigens of Aspergillus. So serum levels that are below 200 international units per milliliter are considered normal. If they're above 200, then you might have it. If it's above 500, then it's abnormal, and you have this condition. Eosinophil counts might be elevated as well. You can treat this with oral steroids to reduce lung inflammation. To kill the fungus, you need to use azoles. The best azole is voriconazole, which is a drug that has its own set of caveats. So, Aaron, you're squinting. Is the writing too small?
Oh, no, I got it.
You got it?
That was
Okay.
annoying.
When I get to the corner,
No, you're
I run out of room, so. All right, so comprehensive treatment plan. And as a nurse, it's gonna be your job to write out the plan, or to, maybe your doctor's office will have this printed out already. You can hand them the plan and to explain it to them, and to explain their responsibilities very clearly. To let them know when there's a problem, when there's maybe not a problem, and also to let them know that you're on their side and they can call you anytime they want, and here's your card and blah, 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 and really let them know that they're not alone in this. Because raising a kid with CF is no picnic, that's for sure. It's also really important that their child be vaccinated for these native nasties and what have you. And that they have to have routine chest x-ray, pulmonary function testing, sputum cultures and what have you. And then these irritants, we talked about this, but dust, smoke, fumes, they need to be avoided. And if they live in an area where the air is quite poor, air quality is quite poor, they might consider moving, or the child might consider wearing a filter mask.
So this can affect like a lot of areas in the body, but it mostly affects the lungs.
Mostly affects the lungs, it also affects the GI tract and the pancreas in particular, and it can affect the liver. So the big one is the lungs, but also the pancreas and the liver.
And it's usually the lungs that ends up being the cause of death.
Yeah, it's usually respiratory failure. The pressure on the respiratory system can also affect the heart too, though, because of the physiological connection between the heart and the lungs. Now, the pancreatic complications, because the pancreas gets backed up and it stops working, you need to, first of all, make sure you screen CF people routinely for diabetes. The way you do that is you give them an oral glucose tolerance test, like the kind you had in your physiology lab, where you had to drink that really disgusting 25% glucose solution. And some of you are looking at me saying, oh, I'm trying to shove that out of my head. It was so traumatic. And then you take the blood glucose levels. The blood glucose levels should go up and then come down. If it gets over 200, that's usually a sign that the endocrine system's not working that well. In order for them to be able to absorb nutrition, they will have to supplement their pancreatic enzymes. And you can buy, unfortunately, they're not cheap, You can buy pancreatic enzymes. They come in this freeze-dried powder, and you add it to the food, and that will help them break down the food and absorb it properly. You really need to make sure that you're checking for proper weight gain, growth, and what have you. CF kids are usually quite thin. And then if they're not absorbing, if not using glucose properly, diabetes might be an issue, and they might have to go on insulin. If the hepatic enzymes are elevated, then you might want to think about biliary cirrhosis. And you can manage that through just oral bile acids. Oral bile acids don't go down easily, but they can essentially dissolve and prevent gallstones. The other biggie, particularly in young women with CF, is bone density. When you're not growing and you're not absorbing nutrients, your bones, as they grow, they get more and more dense. And then at that time, after puberty, during your life, that's about the time they're the dentist and that densest. And then usually they will start to kind of do this. And then ladies get to menopause and things really go south for some ladies. But guys, usually things go south a little less quickly. So if you don't get that maximum bone density, your chances of osteoporosis are pretty high. Also, if you don't have good bone density in responses to stresses, the bone can develop really oddly. And you may need to get braces in the legs and things like that. So you have to make sure that you watch bone density. There's been quite a bit of work on physical exercise. And people with cystic fibrosis, does it improve bone health or does it make it worse? Does the stress on the bone cause it to develop funny? What does it do to the airways? Does it increase inflammation in the airways? The answer from every study that's been done, big studies, small studies, multi-center studies, is that physical exercise helps. Helps with the airways, helps with bone density, helps just in general. Doesn't have to be heavy exercise either. But there are CF people who swim on swim teams and run track and play softball and, you know, whatever. So CF kids can be athletes. But they have to manage their nutrition really carefully. And they need to make sure that they have their proper inhalers with them when they work out and what have you.
I was just gonna see, like, ask if there was anything that they really couldn't do with it.
Weightlifting, probably. They can't be professional weightlifters, I would guess. The amount of calories those people take in, there's just no way a CF kid would be able to absorb that kind of nutrition. It just, so probably being a professional weightlifter, which would include probably, I have not seen many CF kids who are football players. They tend to be tennis players, bowlers, baseball, softball. They usually don't become boxers or something like that. So yeah. Really heavy contact sports. Although I knew a kid who was CF who played lacrosse, and lacrosse is not a sport I call gentle. So, McKenna, probably depends. And I've seen CF kids who are very sick, and I've seen others pretty much manage pretty well. So the severity of the disease is going to vary. We're going to look at muscular dystrophies. Not the next chapter after that, we're going to see those diseases vary wildly as to their severity. It's kind of the same way with cystic fibrosis. The better plan you have in place, the better that plan is executed, and the better you are at getting the kid medical care right away when they have exacerbations, the better the prognosis is. Full stop. Full stop. So there's no cure for the disease, at least at present. Lung transplantation can essentially cure at least the lung part. There's work being done now with an artificial pancreas. It's still in the experimental stages, but it's in the animal stages. There's talk about it going to human stages. So kind of watch this space. There is improved survival of women, and women with CF can become pregnant and can become mothers. But they should receive proper prenatal counseling. And there are healthcare professionals who are specialists who work with people with cystic fibrosis and what have you, who can talk them through some of the challenges and so on and so forth. So some of the associated symptoms, we talked about the congenital absence of the vas deferens and the low sperm counts and what have you. So evaluation by a urologist is warranted. And if you have someone who doesn't have very severe cystic fibrosis, but they don't have vas deferens, there's a chance they have cystic fibrosis. So you want to get that, that's enough essentially to get them genetic testing. So a quick recap is that cystic fibrosis is an autosomal recessive disease. It involves the CFTR gene. It causes issues with lungs and with the pancreas and a few other organs and tissues. Respiratory features will include things like bronchiectasis, pneumonia, nasal polyps, and the allergic bronchopulmonary aspergillosis. Gastrointestinal features will include things like meconium ileus, peritonitis, failure to thrive, pancreatic disease, which will include both exocrine insufficiency, cystic fibrosis related diabetes mellitus. Other features will include male infertility and distal clubbing of the fingers and maybe the toes. It presents usually in infancy and early childhood. The diagnosis will be based upon newborn screening tests, which include the abnormal pilocarpine sweat test, looking for increased chloride. You want chloride levels above 60 nanomolars per liter. People have to have 2 mutations in order to have the condition. It's recessive. Mortality relates usually to pulmonary failure. Chronic treatment includes chest physiotherapy, bronchodilators, mucolytics. In some cases, anti-inflammatory agents, azithromycin, supplemental oxygen. And then there are also CFTR modulators. So we talked a little bit about drugs like ivacaftor, tazecaftor, lumacaftor. Those are drugs that can actually take a mutant CFRT protein, cause it to fold and get to the membrane. If you have the right mutation, those drugs will work. That's the delta 508. The phenylalanine 508 is missing. That's the one these drugs were designed for. If you don't have that particular allele, those modulators don't work. Acute exacerbations usually show new or worsened symptoms and a 10 to 15% decrease in the forced expiratory volume after 1 second. You treat them with antibiotics that target the new pathogen that you find in a sputum culture, and then also things to decrease the inflammation in the lungs. And surveillance guidelines include population screening and so on and so forth. Are there any questions about cystic fibrosis before we move to the next thing? Good chance you guys will see some cystic fibrosis in your practice. Very good. So let's go to another condition that frankly is rather interesting. And that is this condition called osteogenesis imperfecta. Osteogenesis imperfecta. But first, a case report. Cynthia is a 33-year-old mother who gives birth to a male baby. He was admitted to the neonate center for special care. I think that means the NICU, neonate unit for special care, NICU. After birth for an inability to cry at birth. He had multiple deformities in body posture. multiple deformities in body posture. He, in fact, looked like this. He had this kind of frog posture. That's the way babies normally hold their legs? No. What do babies normally do with their legs? They try to change their diaper. Yeah, so kids, they've got their legs up or they have their legs out. This sort of frog posture. Can we agree that's not normal? Okay, we go like this. Yeah, that's not normal. That's not normal. So that told the healthcare workers, and this is in Nigeria, by the way. So that's a little Nigerian chap there. His mother received routine prenatal and postnatal care. Pregnancy was uneventful. The only routine drugs used during pregnancy was acetaminophen. Acetaminophen caused that? No. Prenatal ultrasounds detected no fractures or other abnormalities. The onset of labor was spontaneous, lasted about 8 hours with a spontaneous vertex delivery. That means the head came up first. APGAR score was 4 at 10 minutes. That's a good score. No history of tendency to fractures in the family. No family history of any baby with a fracture at birth. On examination in the NICU, he was found to be in a frog-like position with an abnormal movement of the left thigh. He was in respiratory stress with acrocyanosis. He also had a blue-gray sclera, a blue-gray sclera of the eye. That's going to be very important here in a second. Musculoskeletal system examination revealed deformity of the fingers, fractures of the right humerus and ulnar, fractures of both femurs, and microfractures in essentially the tailbone. X-ray radiography revealed, confirmed the fractures that were diagnosed in the ultrasound. Treatment was mainly supportive with minimal handling, intermittent suction, intranasal oxygen administration. Parents were counseled, the baby was reviewed by orthopedic surgeons, and anesthetists for later surgical intervention when he stabilized. Unfortunately, he continued to deteriorate until he died 7 days after his birth. So not a happy ending on that one. Katie, is that a hand up question or you just, no, okay, you're just some way to hold your pen. No, I just wondered if you had a question. So, okay, so if you do have a question, just throw something. So this is a little chap born with osteogenesis imperfecta. So what is osteogenesis imperfecta? This results from mutations in the gene that encodes the major collagen found in bone. So it's collagen type 1. Collagen type 1. So you have a weakening of connective tissue because collagen type 1 is also found in tendons and ligaments and stuff like that. But it's found especially in bone. Now, it turns out you have genes. Turns out collagen 1 has a couple of subunits. So mutations in any of those subunit encoding proteins, or mutations in genes involved with post-translational modification of the collagen. They can also cause osteogenesis imperfecta. So this leads to weakened bones. Usually you find the weakening and the deformities in the extremities. And that's why this disease is referred to as so-called brittle bone disease. This disease was made famous by the Bruce Willis Samuel T. Jackson movie, where Samuel T. Jackson plays, turns out he's an evil genius who likes blowing things up, who has bones that break very easily, osteogenesis imperfecta. And he's wheelchair bound and so on and so forth. What was the movie called? Sorry? Unbreakable. Yeah. Unbreakable. So there are a few different classifications of osteogenesis imperfecta. They go from the most mild to the most severe, and then kind of in between. So type 1, most mild. Type 2, most severe. And 3 through 8 are kind of somewhere in between. I wish I could say they, starts the worst and goes now it's because they're classified that way according to the order in which they were discovered. All right, so mutations that are not associated with type 1 collagen will cause osteogenesis imperfecta type 5 and 6. These are proteins that are necessary for bone maintenance. These others have are mutations due to mutations in proteins that help maintain the bone structure. So when you make the long bones, you have a cartilage exemplar. You replace that cartilage with bone. You lay out essentially an organic matrix, and then calcium phosphate salts, hydroxyapatite salts, are deposited upon that matrix, linking it together and reinforcing it. If you don't have a proper scaffolding upon which the salts can deposit, you're going to get bone that is either deformed or is weak, or both for that matter. Now, in people with osteogenesis imperfecta, the bone is very weak. So it's not uncommon for the baby to have multiple fractures just because of birth. That's how weak the bones are. Now remember, the long bones of the baby are not fully ossified. So even the cartilage is very weak because of the glue that holds that together, this collagen. That collagen is abnormal. And consequently, you can have kids with multiple fractures. And sometimes you may think that the parents might be abusing them, when in fact you have a kid who just has bones that fracture very easily, because even the examination by the healthcare professional can actually cause a fracture because they don't know that the kid has osteogenesis imperfecta. So some of these are dominant in their inheritance. Type 1 through 5 are dominant. Types 7 through 8 are recessive. The sporadic mutations are more common in the lethal forms. And in fact, this case study that I read to you here, this was a sporadic form, a dominant sporadic form. That question? No, okay. All right. This condition has a incidence of 6 to 7-ish people per 100,000. That's worldwide. 1 and 6 are the most common. Type 2, you can see, is probably the most common, the most severe, 1 in 60,000 births. When it comes to types 5, 6, and 7, those are rare, quite rare. So the occurrence rates is going to depend on which type. 2 is the most common. And 2 also, as you can see here, is the most severe. That one arises most often from sporadic cases. It's not inherited quite so much. Now, these kids can be completely normal at birth. Usually at birth, there's this particular chap here had abnormalities, obvious abnormalities at birth that I showed you. If you have fractures for no evident cause, even at birth, if the sclera of the eye is blue, the mutation in the collagen causes, now the sclera is full of collagen. That mutation causes the sclera to have a bluish tint. That should be one of the things you should check if you have fractures of unknown cause. Check the whites of the eye. If there's a bluish tint, that's a tip-off. You're probably looking at a case of osteogenesis imperfecta.
Is
Yes.
blue sclera only in like infancy, or is that like
It's pretty common, even in adolescence. It's more obvious, I think, in kids, just because the eyes usually are lightly colored. You can see it really easily in babies, but you'll see it if you look for it also in adolescents or teens or something like that. In adulthood too, because the bones of the ear aren't going to work very well, you're going to start to have conductive hearing loss, not sensorineural hearing loss, conductive hearing loss. And that occurs during adulthood. Yes.
how often do any of the types live to adulthood?
The mild forms pretty common, very common. Women with the mild forms, as they note here, during pregnancy, they're very prone to fractures. In fact, OA mothers, the OB might tell them bed rest. You don't work, you don't walk, you don't knit, bed rest for the whole 9 months. Also postmenopause, they're at marked risk for fractures. So they may have to go on these drugs we talked about in farm for osteoporosis, the bisphosphonates. They might have to go on those early in life. Other features with type 2 OI, short stature is pretty common. With multiple fractures, the bones may heal funny. So you may see some limb abnormalities and so on and so forth. Dentinogenesis imperfecta, you see discoloration of the teeth. So the teeth tend to be a grayish or brownish color. They wear down very easily. They degrade, break down very easily. The spine also shows misalignment. So they may show scoliosis, or they may show kyphosis or both. That can be very painful. Standing can, or even walking can be a big issue. Because the rib cage is subject to fractures and the healing of the rib cage may cause abnormalities in the rib cage, that may cause the lungs to be underdeveloped, and respiratory difficulties might be a genuine issue. There are orthopedic surgeries that kids can have. Those surgeries are high risk because you're not dealing with normal bone and you're not dealing with bone that's going to heal normally many times. So very often orthopedists will actually brace the bone. Usually there are artificial materials you can use to brace the bone that will grow into the bone and strengthen it. ligament laxity, that's really common, especially in the less severe ones. So you might have people who can, take their leg and put it over their hair or something like that. With the problems in the lower limb and with the problems in the spine, mobility impairment is quite common. Walking, any sort of perambulation might be a problem. In severe cases, as we saw with that case study, death early in childhood is not that uncommon. It's usually due to respiratory failure. X-rays of the skull. The skull is the place that shows this the best. You tend to see kind of pitting, kind of a pitted structure, and you may see little isolated, the slide here says islands. That's actually a good way to think of it. You'll see little areas of ossification instead of the nice plates of ossification that eventually grow together. Instead, you see these isolated spots that look sometimes like kind of a pitted look to it. And because the bone is so fragile, you have just trouble forming bone in general. And you can get crumpled long bones because of the repeated fractures and healing. That's called acrodyna femora. That's seen most commonly in the upper legs. Types 3 and types 4, 3 and 4, they have this consequence where you can have fractures even with the slightest trauma of any sort. And you get these bumps on the bone, they're called popcorn deposits. That's due to the bone essentially just trying to just go for it and deposit bone, in any sort of way. Type 5, you get the heads of the radius. You get this callus formation. That can be surgically dealt with, but you want to limit the number of surgeries, and then other types of bone issues with type 7, what have you. It's yeah. Wherever you go, there are bone issues. Yep.
I think that, is it possible for them to have the fractures while they're in utero too?
Yeah. Not as common. It can happen though. So the diagnosis is usually clinical. The issue with OI is that because there are several genes involved in its causation, you'd have to sequence all those genes. Also, with 2 of the cases of osteogenesis imperfecta, the gene that causes them is unknown. So genetic testing in this case is not going to be all that useful. So your diagnosis in this case is going to be of a clinical nature. So the blue sclera, that's a biggie because there really aren't any other things that cause that. The bone fragility, multiple fractures, lots of other things cause short stature, but if you see these other things with short stature, the bad teeth, the laxity of the ligaments, and then if there's a family history, those are all tip-offs, essentially. You're dealing with osteogenesis imperfecta. On an X-ray, because of compression fractures of the vertebrae, you get this thing called codfish vertebrae, where the vertebrae start to get, they kind of do this. Instead of being kind of blocks like this, they're tapered and what have you. And you need to make sure you rule out other causes of fractures like nutritional issues, absorption issues, malignancy, or even perhaps a battered child syndrome. If you've effectively ruled those out, and you may then have to involve a social worker, which if it's a parent, they bring their other kids in, their other kids seem fine. by law, usually you're required to usually involve a social worker just to make sure that you can eliminate that, and the parents won't be very happy about that. I mean, why would they be? I know I'd be ticked off about that, but in some states, it's a law. You have to involve them. In Michigan, I think you have to contact a social worker. If you see these types of conditions and you need to exclude battered child syndrome, you have to contact social services. You don't in Indiana. I think in Michigan you do. Again, let me check that, but I'm pretty sure in Michigan you do. The hospital too may have its own policy. So you will get told this time and time again, you'll be sick of hearing it. Always make sure you're aware of your hospital's policy and that you follow your hospital's policy. So your patient, your OI patient, except for type 1, they're going to have to decrease bone mineral density. The degree is going to vary, essentially. A lot of this has to do with the fact that they are sedentary, because if they move, they're going to fracture something. So you can determine this using dual energy X-ray absorptiometry. That is an easy test to do. They essentially lie on a table. You leave the room and you push a button, essentially, and you get this DEXA scan. The DEXA scan will measure the mineral content. It doesn't measure the collagen content. But if that's the case, then they need to make sure they're getting enough calcium, enough vitamin D, so on and so forth. There is physical therapy available for people with OI, and people with OI should get physical therapy so that they get some stress on the bone that they can withstand, because that will help increase bone density. Therapists usually who work with these kids or people or kids are very well trained for it. It's not easy to work with that population. So there are good genetic tests if you have mutations in any of these 4 genes. So these are responsible for making the protein or helping to assemble it. And the type 1 collagen is found in lots of places, not just bone. It's found in skin, it's found in tendons, it's found in there's lots of places, lots of things. So the mutations essentially, these 2 genes, if you have loss of function mutations in these genes, you're going to alter the structure of it. Whereas if you have mutations in these genes, that affects the normal assembly, final structure and folding of the protein. So mutations in the proline hydroxylase gene, they tend to lead to a type 8 type osteogenesis imperfecta, whereas mutations in the cross-linking gene that cross-links the lysine oxidase gene, that's going to give you something more of a type 7 type of osteogenesis imperfecta, whereas mutations in collagen 1 or collagen type 1-2, those are going to give you usually very severe types of osteogenesis imperfecta. So you can get genetic tests for these 4 genes. If you don't find mutations in those 4 genes, it doesn't tell you very much. Now, having said that, most of your cases of osteogenesis imperfecta are due to mutations in those genes. So, should you send them for genetic testing? Yes, you should. If it comes back and you don't find anything, does that tell you that your patient's home free? They don't have OI, it's something else? No. So again, I will continue to bang my spoon on my high chair and say, acknowledge the limits of all the tests that the patient will have or the kid will have. Be honest and open and just tell them, These tests have limitations. They don't tell us everything. We're not God, we're not omniscient. We can just tell you what the test says. We can tell you what we say within the limitations of the test. If you're honest with your patient, they will thank you. Yes.
So it is type 5 and 6 that aren't associated with those 4 usually.
Yeah, they're associated with something else. And the gene that's causes it has not yet been definitively identified. All right, and as usual, I've lost track of time. So we will pick this up come Friday. We will have a quiz on Friday, so feel free to contribute questions to your little heart's content. And if you haven't taken the test yet, please find time to take it. Once everyone's taken the test and I figure out the curve, if it needs to be curved, I will give you a test back. Please try to take it by this week.
So on Friday, I'll probably just be on Zoom then, if that's okay.
Yeah.
Okay. Sorry, the hospital kept calling me and they just called me about what time I have to arrive tomorrow.
Oh, they did tell you.
Yeah.
Okay.
Yep, 11 a.m. So
And you have to be,
probably.
you have to be NPO.
Yeah.
Yeah. You're gonna be so hungry
Yeah.
afterwards, but I don't know, when the anesthetics they gave you,
They said I might get